Now that you've had an opportunity to chew a little bit, we're going to get started with the program. So if you're going to continue to chew, that's fine. Just don't make a lot of noise. So welcome to our third policy briefing, I guess you'd call it, for the campaign to end unwanted medical treatment. And I extend this welcome from the campaign and its collaborating organizations, so there are quite a few of those. My name is Larry Atkins. I'm the president of the National Academy of Social Insurance, one of the collaborating organizations. And I'm happy to be here today as the moderator for this discussion, which just means I get to talk to you first, and then I'm going to sit down and listen. But just to start with, the objective of the campaign is pretty simple. It's really to ensure that all patients have dignity in honoring their wishes, goals, values, and preferences. The campaign is dedicated to ensuring patients and consumers receive the medical care they want, nothing more and nothing less. There we go. So we have a growing group of collaborators on the campaign. We're now up to about 19 national partners supporting the campaign. We have 3 new ones: the Altarum Institute Center for Elder Care and Advanced Illness, the Catholics in Alliance for the Common Good, and the Women's Institute for Secure Retirement. So we're pleased to have these groups join the effort. And also I'd like to take a moment to thank the Consumer Coalition for Quality Health Care, the Elder Justice Coalition, and Compassion and Choices for their financial support for these lunches. So, we started out in December. We heard from Dr. Bud Hammes, the Director of Medical Humanities at Gunderson Health System in La Crosse, Wisconsin. Dr. Hammes has designed and implemented a very innovative and highly successful advanced care planning model known as Respecting Choices that places the person at the center of the decision-making. And then in March, we had our second luncheon with Dr. Bruce Vladeck, that I know a lot of people know or know of, the former administrator of the Healthcare Financing Administration, which is now CMS. And he has been spearheading what is now a 3-year effort funded by the SCAN Foundation known as Dignity-Driven Decision-Making. So he talked to us about that. A brief that was prepared by Dr. Vladeck and Aaron Westfall from the SCAN Foundation that was that appeared in Health Affairs in 2012 kind of characterized dignity-driven decision-making as a process that builds on previous efforts to define and develop patient and family-centered care for those with advanced illness, more a framework than a rigid structure. The dignity-driven decision-making model emphasizes the centrality of a collaborative process in which patients, their families, and clinicians work together continuously to define the goals of care and how best to implement them. So, we've had the opportunity to hear from and gain a great deal of insight from, 2 leaders in this field, and really about models out there that are up and running and working and interesting. So today, we're very pleased to have a different perspective on these issues. And this is a perspective that really comes from the public policy and the political space around these questions. And as you know, these are issues that have in the past resonated fairly substantially in the political world. And so I'm sure we'll have a chance to hear more about that today. So I'm really pleased to welcome Chris Dawe, who is a person who's made substantial contributions to the development of federal health policy, both serving in the administration and on the Hill. Until last week, actually we're intruding upon his post-work downtime. But until last week, he was the healthcare advisor to the National Economic Council at the White House. And in that role, he advised the National Economic Council leadership on a wide range of healthcare issues, especially related to delivery system reforms and issues affecting key populations, including those with advanced illness. Before that, he was the director of delivery system reform at HHS in their Office of Health Reform, where he supported the implementation of the elements of the Affordable Care Act that seek to foster the delivery of higher quality, more affordable health care. And before joining the administration, and actually during the passage of the Affordable Care Act, he was serving as a professional staff member on the Senate Finance Committee for its then chairman, now ambassador to China, Max Baucus of Montana. And there he covered all issues related to Medicare Part A, which anyone who's ever worked in Medicare Part A knows are voluminous. So we're delighted to have Chris here today to share his insights on the various options and approaches to developing high-quality and cost-effective models of care for those with advanced illness, as well as discussing some of the key administration initiatives, such as the recent announcement of the next phase of the Hospice Concurrent Care Demonstration Project, and then hopefully share some indiscretions about, really what goes on in the White House. So we're very interested. So with that, I'm pleased to turn it over to Chris.
Thanks, Larry. And thanks to Brian Limburg, if he's still here. I think he's going to sneak out in the middle of my remarks, but thanks for inviting me. It is, you're on the spot. You can tell him where you're going. It's great to be here. As Larry mentioned, this is my first week outside of public service for a number of years, and I couldn't think of an issue more important to me and to the cause to come and speak to you guys about, and I really appreciate the work you're doing. That being said, the bar wasn't that high to get me out of the house. It's only been a week, but yeah, a lot of diapers. I have a 7-month-old, spending a lot of time with her. I think she's happy to have Dad around, but a lot of diapers, a lot of Hoda and Kathy Lee, a lot of time trying to break in at the playground. It's a tough spot for newcomers, and I don't mean the babies, the adults. You got the nanny, the professionals who are sort of looking at me like I must be some kind of unemployable loser. What is he doing here during the day? And then you've got the moms and the other dads who, are protecting their ground. So it's good to be here with you all talking about issues of national public policy importance. But in any case, and I'm happy to take questions on any of that stuff. But what I thought I could do is talk a little bit about the perspective from the administration as I have to be careful with my we's and they's, as they are looking to implement healthcare reform, both using the sort of new authorities and resources and vision in that legislation, but also sort of existing authority to really help be a partner in the evolution of the healthcare system towards providing care that's of high value to purchasers and, of course, to consumers. So I want to give a little bit of the context in how the administration and its allies have been sort of proceeding with their work, and then talk a little bit about the new Medicare Choices model, or otherwise sort of known as a concurrent care model that was recently announced, that is a really exciting and important addition to the portfolio of models that are being tested, mostly through Medicare, but in some places with dual eligibles, with Medicaid, and with private payers. So I want to sort of set the context, talk a little bit about that, and then I think it would be really interesting, fascinating to me to have a discussion about what might be next, and thinking about advanced illness management, if you will, more broadly than just concurrent care and folks who are hospice eligible, thinking a little bit upstream. And what does that mean for the sort of big picture trend and toward accountable care, if you will, and how a potential model around that may or may not fit into the landscape as again, I think both public, private payers and others are trying to find ways to be supportive partners of healthcare deliverers who are thinking about how they can kind of change the way that they do business and practice care in the sort of new American healthcare system that hopefully is developing. So that's sort of the general approach, and I will try not to blab on for too long because it's a great small room. We can have a pretty good discussion. So just sort of stepping back textually, as I mentioned, the general idea that we need to move a system from one that is really focused on, again, you guys have now heard this has become cliche, right, that move from volume to value, And that is now, I think, a consensus position, which is nice for those of us who have been doing this for a long time and feel like, the idea of quality and value was always sort of off to the side, and now it's becoming ingrained in everything we do. And I think that idea that getting more value out of our healthcare dollar is the solution to improving quality, making healthcare more affordable for patients, families, governments, employers, you name it, is one that's shared from the U.S. Chamber of Commerce to the Center for American Progress. I mean, there's really not a whole lot of debate there. I think the real question is, how do you get there from here? And as all of you know, the healthcare system, there is no single huge healthcare system. It's a very local and regional market, and there's no one way to flip that switch overnight. And so the approach that the administration's been taking, again, given some resources, authority from the Affordable Care Act, is how can we be a partner in helping folks at the local level kind of unlock innovation that they know can work where they are. And so they have really approached this from really three big buckets of policy work, I would argue. So payment reform, which is sort of, I think most people would argue, is one of the main and first to recognized barriers to really unlocking healthcare that is really value-driven. So how do we change the way the money flows so that it's actually rewarding for folks financially to keep people at home in the community, out of the hospital, et cetera. The second is around data liquidity, if you will. How do we unleash the treasure trove of healthcare data that certainly Medicare and the federal government's been sitting on for years, but also a lot of private payers. So how do we get that information out into the hands of certainly to providers who are now thinking about, okay, how do I think about managing a population of patients or managing an episode of care that might be beyond the four walls of where I practice? So how do I get my hands on the information I need to be able to make sure that I'm providing patient-centered, high-value care, but I can track that and know and make adjustments and know how I'm doing. So data for providers, absolutely, and for consumers to put more information in their hands so they can be more empowered in the way that they shop for care, shop for insurance, you name it. So payment reform, data liquidity, or transparency, availability, whatever you want to call it. And then the third being practice support and sort of infrastructure development. This is one that I think was a really important legacy of Don Berwick, who I'm sure many of you know, who is a terrific public servant and a great guy who I had the privilege of serving with for all too short of a time, and I think you guys all know that story. But one of the things that he really ingrained in us as we were pushing this agenda forward was you can't just change the payment system, throw some data at the marketplace and say, good luck, we'll see how you do. If you really want folks to have an opportunity to succeed, you have to help them, meet them where they are, and help them develop the capacity, the tools, and the infrastructure to actually succeed in this new environment. And so there's been quite a bit of work in things like hospital safety and the creation of hospital engagement networks. These are 26 groups that were contracted from CMS to go and work with 4,000 plus hospitals and essentially divvy up the hospital market. And their responsibility is to transfer best practices from higher performing hospitals on patient safety to lower performing hospitals. And in the first year or 18 months, we asked them, okay, focus on six critical areas, 6 conditions, 6 hospital-acquired infections, whatever you, there were a list of 12 or 13 that were a part of this Partnership for Patients initiative. Focus on 6 and see how much you can do by really flooding the zone. So after 18 months, all 26 of those hospital engagement networks had improved each of their 6 conditions by more than 30%. So that is real world impact that can happen very quickly when you line up. And importantly, there's a payment incentive coming down the line here in a couple of years where hospitals are going to be increasingly penalized for having a disproportionate incidence of safety issues. So the idea of matching an impending payment consequence with some support for transfer of knowledge with data, it can work, and it can work pretty quickly. Along the lines here as well, any of you who have maybe been involved in an applicant or someone who's participating in a pilot with the CMS Innovation Center, all of the models they run include a sort of best practice learning network and dissemination effort to make sure that it's a very interesting to me departure from the old way of testing innovation in the Medicare program, which was we've got an idea that seems like it could work. here's the way we think it should be structured. Providers, if you're interested, sign up. So folks would come in, sign up, great, we'll do it. And then set them off. We'll see in 5 years when we have a third party write an evaluation. We'll see what happens. That is, we sort of flip that, or they have flipped that to say, come on in, let's get working on this. From day one, you're going to be a part of the learning collaborative with other folks who are trying to do this. And we will iterate along the way and make sure that, because in the past, it was the story was always the same. You get 20 sites participating in a Medicare demo. 5 hit it out of the ballpark, 5 really stink, 10 are somewhere in the middle, and the thing's declared unsuccessful because it didn't overall save money and didn't have a majority of people. No one took the time to help those 5 let the others know how they were doing and what they were doing in their local environment and conditions, and hopefully transfer that. So that's a part of all the models. But I skipped a little bit on the payment front, which is where there's quite a bit of work. Again, the vision is that there is no one-size-fits-all or top-down solution to this. If there were, it would have been done by folks far smarter than the folks in the administration now, and we wouldn't be in this situation. So the idea that local markets, and even folks within local markets, are all in different stages of readiness and maturity. You've got to let them build their own transformation journey, if you will, by allowing them to take part in a number of different options. So if you think of it on a continuum, between the Innovation Center, between the traditional Medicare program, some work in Medicaid, we've got stuff for the folks who are just getting started. So if you want to adopt a health IT system for the first time and meaningfully use it, there are incentives that I'm sure many of you are aware of, so you can get that kind of basic infrastructure. I think we would all agree that providing population-based care, high-value care would be impossible without having that infrastructure foundation of healthcare information technology. If you want to start working on readmissions, we have a lot of different programs that focus on making sure that people transition successfully from an acute setting, either home or to a post-acute, where there are a lot of gaps in care today. If you think of that as a very short episode of care, the CMS Innovation Center is running a bundling program that's paying along episodes. There are about 48 different episodes of care that range from things like hip and knee replacements to even things like COPD, so getting into more of a disease-based episode, where folks are taking accountability for the inpatient stay and 60, 90 days post-discharge, and being responsible for that entire episode of care. So that really, once you start talking about that length of time, then there's no way to do this without sitting around the table with partners in your community and figuring out how are we going to come together to succeed on making sure we're hitting quality benchmarks and hopefully spending a little bit less on this episode than we thought we would. And then there are options to start getting into more population health. So many different flavors of the patient-centered medical home. The one that I find most interesting is called the Comprehensive Primary Care Initiative, where the CMS Innovation Center actually started with payers first as opposed to providers, and said between commercial payers, state Medicaid programs, large employers, if you're interested in purchasing primary care in a different way, if you want to team up with Medicare, come on in, let's figure out what we could do together, and then we'll go as a united front to the marketplace and offer a primary care practice the opportunity to really change the way they work across the vast majority of their patient panel. So we did that. 500 primary care practices signed up overnight. We're really excited about that. So that may be a place where they can replicate that approach. Then, of course, the ACO, Accountable Care Organization model, is being tested in a few different ways, from those who just want to get started and meet some quality targets over a population, spend a little bit less than we thought, we'll share in some of the savings, to those our pioneer ACOs that have had some experience in managing care in the past, who are really looking to move into more of a population-based, prospectively paid financing arrangement within traditional Medicare. So we have them on a track. So again, it's sort of a continuum of, you could think of it of providers taking risk. You could think of it as the amount of and how deep you need to go in your community to actually put these things together. So there are a number of different options. So payment, data, practice support, happening in tandem. And the results are encouraging. Readmissions in Medicare are down for the first time in a long time. I think it's up to about 150,000 readmissions have been avoided in the last 18 months. So you can kind of see that curve finally bending, which is terrific. The pioneer ACOs grew at half the rate of the traditional Medicare program. and still met all their quality targets. I mentioned the patient safety, and of course, I don't think anyone's claiming that any of this work is solely responsible for the recent slowdown in health costs, but for my money, it's hard to argue that it isn't playing some role. Clearly, the effects of the recession play a part there. I think the best data point here is if this were all about the recession and price sensitivity on the case of consumers, then you wouldn't be seeing a slowdown in Medicare because, as many of you know, Medicare beneficiaries are largely shielded from a lot of point-of-service cost sharing. But we've seen Medicare slow down as well. So something structural is happening. And the question now is how does the kind of royal we and those of us who care about this in the marketplace take the next step and accelerate across each of those things. So that will be I think the large thrust as the national conversation here, I think, quite naturally and rightfully migrates from one that's healthcare reform is all about getting people signed up for insurance. It seems pretty clear that that's now working well. Now the conversation, I think, is how are we going to afford our healthcare future in terms of providing high value, cost-effective care and ensuring access. So that kind of brings back to this idea of why concurrent care, why Medicare choices. Again, I think if you think about that continuum, the goal here is to have a portfolio where providers from all different parts of the care continuum have an opportunity to participate in a model of care that is focused on the three-part aim: better health, better care, lower costs. And there was the feeling that, as all of you know, there was great gaps in care, a lot of issues in terms of healthcare outcomes and quality, unnecessary pain and suffering, and certainly, not a great cost situation for folks who were in advanced stages of illness. And for a long time, and the Medicare rules for the main program still state that if you move into hospice, then you are foregoing curative care for that condition for which you've been determined hospice eligible. But there's been a body of evidence that suggests that a concurrent model where beneficiaries are allowed to continue seeking curative care but start to get some of the care coordination, some of the pain management, some of the home and community-based services that generally accompany various hospice models. If they can start to do those things simultaneously, that there are upticks in quality of life, in quality outcomes, and to the extent that folks get into hospice a little earlier, there's the possibility for saving some money. There's I believe it was a University of Michigan study that was funded by the Robert Wood Johnson Foundation. That was, I believe, a randomized controlled trial on this, which is, as you know, the gold standard. So there's quite a bit of evidence base, and I think for me, it took too long to get here, but we can come back to the politics, and I think we all know that there's been some folks being a little gun shy about jumping back into this space because of the way that it was demagogued in the legislative debate. But clearly, whether it's Senator Wyden, who has cared about this for a long time, I think there's a growing group of folks on the other side of the aisle who for a long time, I think, have believed in the policy, but are now feeling a little bit more comfortable on the political side. And of course, the administration now saying this is the type of thing that fits in pretty nicely. So the model, for those of you who haven't seen it, will have about 30 hospice practices serving up to 30,000 Medicare and dual eligible beneficiaries who are hospice eligible. So they have to meet the traditional 6-month definition of hospice eligibility. But rather than enrolling directly in the hospice benefit, these sites will enroll them in the Medicare Choices model, in which they can continue to seek curative care, but the hospice will serve as a sort of care manager, coordinator, and kind of advocate and quarterback for those beneficiaries and their families. Very, very patient-centered model. So to me, very exciting. I think it fits in really nicely across again, this continuum of payment reform opportunities, and they'll have it up and running fairly shortly, and then obviously the goal is to get some data back from the field as quickly as possible. And with the new authority of the Innovation Center, should this model prove to be one that is at least keeping quality the same or improving it and saving a little bit of money by expanding it, then the Innovation Center could make this a permanent part of the Medicare program without going back to Congress, which is really huge. And I have to give my former boss, Senator Baucus, Ambassador Baucus, a lot of credit for putting that in the law. I mean, that's a major handover of policymaking prerogative from the legislative to the executive branch, but I believe it was the right thing to do. So would love to hear feedback for those who have been digging in on this model a little bit. It's a process in which there may be opportunity to make tweaks to the model before it goes live. So I think it'd be really fascinating to hear a little bit about that. And then finally, as I mentioned earlier, this is still in the concurrent care model, still a population that has reached quite a bit of advanced state in terms of where their illness stands, with a physician saying 6 months left. And I think one of the interesting questions is there a space here a little bit upstream, if you will, from that, where you get folks who may not be that advanced but are very ill and very sick and have some very complicated needs. And I think the question, and I don't know the answer to this, quite frankly, I would love to have a discussion here about it, is there a space in between, say, this new Medicare Choices concurrent care model and some of these other existing programs, things like ACOs and medical homes, that in my mind, if they very well may have beneficiaries who have been attributed to their ACO. They're part of the population that the ACO or the medical home is trying to manage. And I think if they're worth their salt, they're going to look at where is the spending happening, where are there major gaps in quality where we can really move the needle and show improvement. So to me, I think they'll go after those folks, and that may be happening already. But I think the question is this a segment of the population that has such specific and advanced needs that it needs to have its own particular payment data practice support intervention. That very well may be the case. I think one thing to be cognizant of is if part of the goal here is to expand payment to take in more of the episodes of care as patients actually experience them, and thinking about how to manage a population, I worry that we don't want to segment out the entire healthcare market into different types of populations of patients and then potentially risk heading back into kind of a siloed arrangement. So I think that's a tricky policy question that that I think will be next up for the administration as they figure out if there's another dimension here. They are, in fairness, testing that model, if you want to describe it as advanced illness management, very similar to what the folks at CTAC spend a lot of time thinking about. In the first round of the Healthcare Innovation Awards that the CMS Innovation Center put out, there were 2 sites, one at Sutter in California and one in University of Pennsylvania, that are looking at this particular space in the sort of care and population continuum. So we hopefully will start to see some data from them that could very well turn into those innovation awards are meant to be kind of the farm team of the 1,000 flowers that hopefully a few bloom and they become the next model for broader testing. So I'll pose that as something for discussion. And with that, I think I'd love to open it up. Happy to talk about policy, politics, whatever's on your mind. But thanks again for having me. Yeah.
On the Sutter and the University of Pennsylvania demos, if you will, are they using, do they allow a curative approach in addition to a hospice approach? Or do they only bring in to the fold of those kind of very coordinated care models folks who have decided not to use curative approaches anymore?
My understanding, and I'm going to maybe ask Andrew or Tom to chime in here because they're vastly more familiar with the Sutter model than I am, but my understanding is that is a group that's not necessarily hospice eligible. I believe they're still potentially seeking curative care. My understanding is that it's also characterized by a community and home-based approach as opposed to, say, palliative care in the hospital setting, for instance. But these guys can jump in here.
Exactly right. They use the microphone.
The Penn model, I don't know much about the Penn model, quite frankly, except that it's generally in the same realm.
And I just get one other part to that. One other part to that. On the new hospice demos you're talking about, is there any flexibility in allowing someone who doesn't have a doctor saying they only have 6 months? Is there any ability to back that out a bit so that someone who might live a year? I mean, instead of having the doctor basically fudge it, allow that demo to some flexibility?
I don't think so. I think that the sense of the folks at the Innovation Center is that this is a place where the evidence suggests that where the most evidence suggests there's opportunity for improvement. I think that it's been mostly in the already hospice eligible world that you've seen, like the Michigan results. There are a few, I think, some work that Aetna's done with perhaps in their Medicare Advantage, or not in their Medicare Advantage, but in their commercial space, where it's been mostly, the evidence base is mostly around the 6-month mark. And so I think that, but what you're getting at is sort of the question I'm posing, which is maybe there needs to be something separate that doesn't look quite like this, and maybe it's not run out of a hospice, but it's some other entity that looks at people that are a little bit upstream, year, 2 years. I don't think it has to be a number, but it could be just some recognition that there are folks who might, that might sort of migrate out of the capabilities of even a very strong medical home and into something where they need another level of support and service, but they're not yet hospice eligible, if that makes sense. So I think that's the question, whether it makes sense to test that as a standalone or think about how to take best practices from the field of dealing with that population and kind of infuse those into the practices of ACOs, medical homes, and others who are, I think, are increasingly having the incentive to try to manage them well. Yeah. I'm sorry, but I should just mention one other thing about the demo before I forget. It's 30,000 beneficiaries, Medicare, fee-for-service, or dual eligible, but in 4 disease states, so advanced cancer, congestive heart failure, COPD, and HIV/AIDS. So it's not for all potentially for all hospice eligible beneficiaries, but for those in those areas. Sorry, apologize.
Sure. As we look at the innovations and the demonstration projects, what is the administration doing around communities of color in terms of the outreach component for that?
It's a good question. I'm not sure if there's anything that's specifically targeted. I think there's a feeling that that should this work be successful, I think that some of the disparities, whether they be race, gender, whatever, will improve because I think that if you look at where there are real gaps in care, I think there's some evidence that suggests that it's disproportionately hitting folks, from minority groups, and not just, again, based on socioeconomic status as well. So I don't know that there's anything in this particular area that's specifically targeted. If you have ideas, I'm sure they'd love to hear them. And there's a big debate about whether some of these more traditional payment changes, like penalizing hospitals for their rate of readmission, whether that should be adjusted, not just on severity of patient, but on their socioeconomic status. And to date, Medicare, the administration has not done that, but MedPAC, NQF, I believe there was a RAND study, there's sort of an increasing body of evidence and important, credible people saying that you might want to do that. Because the fear is that without that, you may see providers avoiding folks who are the toughest to treat. Yeah.
Thanks for your presentation. I have a question on the concurrent care demo, and you teed it up nicely by mentioning the 4 disease states. And I was curious if there was a reason that Alzheimer's and/or dementia was not included.
I don't know. I don't know exactly. I believe generally the Innovation Center's approach is to, while they're in the business of developing an evidence base and trying to test these things on a broader scale, they generally follow where there's been at least some evidence in at least a population or two. And so my guess is that they followed that, the evidence pretty closely. But I don't know exactly how those 4 got chosen.
Are there any policy initiatives on the state level?
Yes. In this particular area, not that I can think of off the top of my head. I think there are certainly complementary approaches that states are taking on the general move the sort of healthcare financing towards healthcare quality and cost effectiveness. I mean, I think that we have, or the Innovation Center has a program called the State Innovation Model, where they've asked states to come in and propose a statewide, multi-payer, multi-stakeholder approach to re-engineering healthcare delivery in the state, and then importantly connecting that in with the public health and some other population health elements, recognizing that individuals spend 99.9% of their time outside of the four walls of the healthcare delivery system, and there are many, many non-clinical determinants of health that you would want to kind of loop in here. So CMS is working directly with governor's offices who have the capability to connect Medicaid payment, state employees with the things like housing security, transportation, food security, all the things that you can imagine a healthcare provider thinking about investing millions, tens of millions of dollars in improving the health of a population, and then when they go home, they can't get around, their housing situation is unhealthy, you name it. And so I think there's some really innovative work on the state level bringing that entire system together. There are about 6 states doing that, and the administration will open that up to another 10 or 14 this year. To me, that's the most exciting stuff happening on the state. But there are many others in terms of states pushing on readmission rates, and obviously a lot of move toward managed care organizations in the Medicaid program. And I think there's a bit of a question mark there about whether that's really the state just trying to hand this issue off to private payers, or whether they really want to push those payers to in turn work creatively with their healthcare provider partners. Yeah.
I've noticed some studies that show great promise in along the lines you were talking of intensive outpatient case management, bringing down admission rates and so on. And do you see in the future Medicaid, Medicare providing not just pilot, but just broader funding for intensive outpatient case management in the community, particularly for advanced illness?
Yeah, I mean, I think part of it is a kind of a definitional thing. I mean, in my mind, a real patient-centered medical home model to me is intensive outpatient case management. You may be thinking of something more nuanced, but I think that's obviously a model that people feel very strongly about, and hopefully very shortly there'll be sufficient evidence to make that a more generalized and permanent part of the Medicare program for primary care physicians. I think that there are, in the meantime, there's been some work, and there's opportunity to build into, say, the traditional Medicare program and in the annual rulemaking and payment cycle, taking lessons that we already know and elements of things like medical home and outpatient case management that we know work, and trying to find a way to build those in. So a couple of examples in the past couple of years have been a payment to primary care clinicians in the outpatient setting for doing what's called a warm handoff as the patient leaves an acute care setting. If the primary care practice is able to see that patient in a 48-hour, there's some time frame, then there's sort of an additional payment than today. So that's something where at least starting to build in. I mean, that idea of the warm handoff and the transition has quite a bit of evidence behind it. So that's something that you can just build straight into the Medicare program. More recently, there was an allowance for clinicians to bill for essentially non-face-to-face encounters, and starting to think about how you can reimburse for a lot of the work that's not traditionally paid for, but is obviously foundational to really managing a population, which is emailing and phone management and those types of things. So it's starting to get there, but yeah, I think that's, I mean, the world is moving out of the acute care setting and into the ambulatory community home. I mean, that's the solution here. And so I think you'll see increasing attention to both kind of big transformative models and on the kind of nuts and bolts, making sure that it's being supported beyond just a pilot.
Hi, Chris. Thank you for your comments. I enjoyed them. I have 2 questions, but I'll keep them short. The first one with the concurrent care model, you mentioned it's not live yet, and When is that supposed to, when is the timing for that? Do you know when that's supposed to?
You know, I
Start?
believe that generally there's about a 60-day window, it could be 60 or 90 days, where CMS asks folks who may be interested to file a letter of intent, essentially, which is kind of pro forma. Yeah, we're thinking about it, and sort of get in the queue. And that gives the Innovation Center a general sense about how many people may be interested. From there, they then allow a handful of months to go before they actually, require the applications to be sent in. And then, interestingly, it's about I would say generally from a 9 to sometimes as long as 18-month window before they go live, which is probably one of the reasons that you hear people say, oh, this innovation center is kind of a flop. They haven't done anything, and they haven't scaled the model yet. And I mean, I share frustration that there hasn't been more. But what was interesting in my experience was even when you have organizations, healthcare systems that are very eager to get started, they find that that there's an awful lot of work before they're ready to flip the switch and do something different. And that's where you get these long I mean, in our bundling project, for instance, we announced it on the day of the earthquake. You guys remember that a few Augusts ago? And it just went live in January. It's a long lead time to get for folks to be ready. So everyone's trying to think how to cut that down, whether it's the clearance process internally or finding ways to help providers get there more quickly so they can get started. But you can't push people too far, or else they may not participate at all.
And then the other question I have is more general. You had mentioned unleashing Medicare data, and we saw that happen this week with the providers' information. But I wonder, from your experience at the White House, or if you have any idea of, are there going to be ways to help translate this for consumers? I mean, people can look up their doctors, but it's a lot of information, but it's not quite user-friendly yet. And do you know if they're going to be working towards that? Yeah,
I mean, it's an interesting debate. I mean, I think that to me, the most important thing is that information be available in machine-readable, downloadable formats, right? I mean, and there can be, for instance, in the Blue Button. So Blue Button is you all may know, is an option for Medicare beneficiaries where they can go online and essentially get their claims history downloaded for them. But as Brenda's pointing out, a lot of folks, it's a huge list of every lab test and every doctor. What are you going to do with that? So the Office of the National Coordinator of Health IT had kind of an innovation challenge, and they selected an application provider who created something. I believe it's called iBlueButton or something like that. That allows you to download and put that into a format which is much more user-friendly. So to me, the most important thing for the federal government to do is make the data available, and I just don't think that government coders and developers are going to be able to keep up with the times here to make sure. So it's a sort of unleashing and bringing in these new. What's exciting to me are the number of people who are getting involved in healthcare and healthcare value creation that have never done anything in healthcare. They just see an opportunity. It's a lot of sort of tech types who see an opportunity to take, where there's been an information gap that's now being filled, and put that into, really attractive and usable. This is essentially the Cast Light story for those who are familiar with that. So to me, most important is get it out there. I think the private market will come. If it doesn't, then sure, they can try to come up with their best apps, but I'm skeptical.
Great. Hi, Chris. Thanks for your comments. So I'm with NACI, and we just put out a paper on the duals demos and quality measures. So I'm kind of hearing things through that framework.
Yeah.
And when you mentioned about for the concurrent demo, if that goes well, CMS has the power to make that a permanent part of the program. How does that translate into better quality measures, so that, for example, if states are doing a demo with Medicare, that they can incorporate some of the best practices? And when you look at the duals demo, there's the quality measures are sort of hit and miss. Some areas are covered really well, other areas, end of life, long-term care, less so. So.
Yeah, I mean, just broadly on quality measurement, I mean, I think that we're in a lot better place than we were certainly 10 years ago, and I think even 5 years ago. And I think those who have used that as a reason or an excuse to not move forward, I think don't have much to stand on anymore. Do I think quality measurement is ideal yet? Absolutely not. I think part of this is kind of learning as we go, and I think that at least speaking for the administration folks, I think they're in a pretty good place and frame of mind of being open to seeing what's working, and hopefully with a little bit of funding, and you can't count on that these days, but a little bit of funding to make sure that gaps in quality measurement are being filled, not in terms of development, and then of course the sort of consensus-based, whether it's NQF or some other entity, confirming the validity of those measures. I mean, that work needs to continue. So I think it's kind of a learning system here as we go along to make sure that we've got the best. And I think increasingly the folks on the public side are going to be looking to align more closely with the private sector. I mean, if you think about, I've been sort of talking a lot about very sort of Medicare and some duals and a few Medicaid-led projects, but you go talk to Aetna, Cigna, WellPoint, a regional Blue Cross of Massachusetts they all are doing things that are slightly different but in the same vein. So that, to me, that gives me two conclusions. One is that we're all sort of tracking together, but I don't think that the totality of that is sending as clear a signal to the marketplace, because I think you still have a lot of folks feeling like, hey, yeah, something's going on. The ground is sort of shaking underneath us, but not sure if this is something that happens in a big way in the next 2 years, 5 years, 15 years. I think there's a lot of uncertainty, so there may be an opportunity for public and private stakeholders to more clearly set some goals and put some timelines around this. That's one, but then in terms of the nuts and bolts, they're a great opportunity to have public and private look at one another and say, not everything will be lined up, because the Medicare population is different than the commercial population, and the pediatric population has different measures. There'll always be some differences, but if we're all measuring, diabetes care, I would argue, don't try to conquer the universe here, grab a disease state or two. If we could get the vast majority of public and private payers agreeing on a core set of measures for diabetes, COPD, and CHF, that would be, I think, do a world of good and be a template for some broader measurement rationalization. Hey.
Hi, how are you? Thanks for the comments today. So much of what I hear when I travel across the country from doctors, from providers, is the difficulty, not necessarily of a diagnosis, but of a prognosis. So a lot of the care that gets provided, particularly in Medicare Choices, that requires kind of a prognosis of 6 months or whatever that might be. I share your concern about the intermediate space, and what I refer to as the soft landing. For everyone, because the trajectory of death now is so different than it was in the past with episodes of care. And so I guess part of the difficulty that I see around that is not just the doctor's inability necessarily to prognose, but that so much of this effort is happening around the providers, and encouraging providers to somehow all of a sudden become medical educators, both to doctors and to consumers. And that's the leg of the stool that always seems to be missing, is how do we empower consumers around an understanding of the death trajectory today, an understanding of what medical care cannot do and can do, and be able to give them an understanding of how to access all of this new provider, patient-centered care when you don't know anything about the fact that death has changed in some ways. Are there, within the Innovation Center and within HHS, are there increasing efforts or programs that would look at public education, that would look at something like smoking cessation programs that have happened in the past to educate consumers about the trajectory of death, what's happening with healthcare providers and the whole system that you're creating?
I don't know that it's necessarily around the trajectory of death at this point, although perhaps some of the work that AHRQ, the Agency for Healthcare Research and Quality, is doing may get into this. I think about AHRQ, I think about the Patient Centered Outcomes Research Institute, PCORI. I think they have part of their mission, and what they've been saying is, the idea of disseminating information and educating consumers, I think will be part of what they do. In terms of provider versus consumer, I think it makes sense. You have to start, I think, on the provider side to make sure there's something there for people to go to that's a different product, a different way of getting healthcare. So we're starting to see that kind of proof of concept in a few places. But then, one of the things that keeps me up at night the most about this whole thing, and as exciting as this opportunity is, that might be a once-in-a-generational opportunity to really redefine the healthcare system on terms that is very much about empowering patients and consumers and not about meat cleavers and just hitting budgetary numbers, because that's the alternative if this doesn't work. But I think one of the biggest threats is the lack of awareness in the consumer and patient communities about what's happening. I mean, I think there's, number one, a lot of confusion generally about healthcare and healthcare reform right now. And to the extent that I think anyone outside of the healthcare industry thinks and knows about that, they would say, well, that's about insurance and the insurance marketplace, new reforms, signing up. And this idea that there is a sort of a groundswell of change and reform in the way that care is practiced and delivered, I think would blow the minds of most people. I mean, I test these things on my parents, who are pretty savvy. They have no idea what an ACO is, a medical home, what? I mean, that sounds scary. I mean, it's not there, and I think that it's hugely important, whether it's about this particular issue and folks who are dealing, with advanced illness and trajectories that you're discussing, it just sort of in general, people who are probably, while they know the healthcare system's not perfect, are probably, more afraid of the devil they don't know. And when this starts to get serious, meaning one, too many of these models, just take Medicare, start panning out, and now CMS is faced with a decision: do we want to make this the new way of doing business? That's something that will really disrupt the status quo. That's when you start to, I think, hear, and we even have heard stories from some pretty prominent ACOs, once they've set up shop, their patients come back and say, well, my cardiologist was sort of whispering, I don't mean to pick on cardiologists, but was whispering in my ear that this ACO thing is kind of like getting care on a budget. There are many potential losers here. Not everyone can win and healthcare costs come down. And so when that happens, I think if there's not some groundwork laid immediately to help people understand that there is a better way of getting healthcare, there's a different product out there. It has nothing to do with you losing things. It has much more to do with you getting things when you want them and where you want them, and getting trusted advocates to help you navigate a complex health system. You can sell that. So it needs to happen now, but it shouldn't be the government, and it shouldn't be insurance companies. It should be doctors, nurses, maybe hospital systems, and trusted institutions that consumers and patients look to for guidance. I think one of the most important things is that those groups start to take more. I mean, I tell provider groups all the time that if they're not spending as much time thinking about how to educate their patients about what they're doing and how it's different than they do about attribution models and the whole black box, they're crazy. Because this, as soon as this feels like, the worst of managed care again, it'll be over. I didn't mean that to be so pessimistic. I mean, there's still a great opportunity. It's just we got to get on it here.
Cool.
Thank you for being here. Sure.
It sounds like there's a lot of innovation that's within the Affordable Care Act. Can you talk about something that is going to require Congress to act that's outside the Affordable Care Act, that's sort of going to be Affordable Care Act 2.0? I'm
glad you mentioned that. I mean, ACA 2.0, that's kind of a funny concept. I don't think we'll see those exact words anytime. But, if I think of what where the gaps are, is, again, until such time, and even after, there have been some of these models that have been scaled and are more in the kind of mainstream Medicare, Medicaid programs. A lot of this stuff is still happening voluntarily and probably will for some time, just because, as exciting as a lot of this is, it's, in my mind, unfortunately, still a relatively narrow sliver of the healthcare marketplace that is really investing and going all in here. So you got a lot of people hedging bets and a lot of people maybe still not doing much of anything. So the question is, how do you start getting them moving and at least doing something to help define the future of this thing? And so you look at something like the SGR legislation that was agreed to, at least on a policy basis, between Democrats and Republicans from the committees on Capitol Hill, that laid out a framework which was, we'll give you a period of stability. This is defining physician payment in Medicare. Give you a period of stability while these models mature a little bit, but starting at date certain, if you're not at least participating in one of these things, then your payment's down here, and if you are, it's up. So creating a financial differential to incentivize participation in one of these models, to me, is hugely needed. That was, a little bit of that was behind the creation of IPAB. You guys remember IPAB? I haven't seen much of that, but that idea of a backstop to say, here, we have a window here. If it doesn't happen, then we're going to come in and really push you guys to do something that you may not do totally on your own right now. So that to me is a great example of legislation. It's bipartisan. To me, that's a great endorsement. It's not surprising that these issues of improving healthcare affordability through improving care delivery is something that has always been bipartisan. It's been under the radar a little bit because it hasn't been the political football of some of these other issues. But even though that didn't pass this year and its future is a little uncertain, just getting prominent Democrats and Republicans around a table to agree to that as a structure for moving providers potentially at a pace that they may not be ready for, I think would be a great step. We'll see.
Thanks, Chris, for all of your points thus far. I had a question really about what's happening at the bottom end regarding personal care aides and home health aides, since they're the real folks that do the lion's share of the personal care.
So just sort of what's happening administration-wide?
Administration-wise, also in terms of making certain that the funding for them and the training are consistent with what is being expected in terms of the changes within the system.
Yeah, I mean, this is not an area that I have unfortunately recently spent a lot of time in. I would say has not been a major thrust. It was not a major thrust. There were elements of the Affordable Care Act that included, things like support for home and community-based services. I would say that the administration hasn't spent as much time on this. I mean, I think figuring out what to do next was a lot of the impetus behind the Long-Term Care Commission that Larry chaired, and kind of figuring out where we go next. In the meantime, I think that honestly, I think it's kind of a steady state. There may be really important smaller initiatives that I'm not aware of. If folks know of things, chime in. There's a lot of activity, obviously, across the administration, but I would say hasn't risen high on the radar screen yet, quite frankly. Yeah. Did I miss something, Larry? Or what's going on? What else is going on that I forgot to mention?
Well, no, I mean, I think the thing that happened in the Labor Department with applying the Fair Labor Standards Act to direct care workers and stuff, I think that, that's going to have some significant effect going forward. And I think to the extent that states begin to work more aggressively on standards and training, it's really important. I see a future in which you can develop a higher level of skill in that workforce with quality standards and certification requirements and better linkage for them into the care network and part of the care team and stuff, where with higher compensation, and you're creating career paths, you could have a much more stable and higher quality workforce. So I do think the commission talked about some of what that path forward would look like. But I think the only thing that's been done, administratively, legislatively, has to do with the Fair Labor Standards.
Yeah, that's right. Appreciate it. Can I add to that?
And I don't know the details on this, but there also is an important Supreme Court case coming down, and while it's Harris v. Quinn, and it's going to be probably seen as a labor case, and that's probably where the biggest impact is, but it may have ramifications for supply and a whole bunch of elements of the labor market.
Appreciate that. Yeah.
Hi, I'm Kristen Santiago with Sea Change. I just have a specific question a little bit about the $400 per beneficiary per month. Do you know how they came to that number and if it's adequate and if people will succeed with that level of reimbursement?
Yeah, I think when you see a number that's flat like that, you can assume that it wasn't completely science-based, right? I mean, I think there was some, obviously some evidence from the field, but I think a little bit of that was kind of like your best guess, kind of trying to price that out. And that's one of the places where I think, and even in some conversations before I left the administration, folks think, there was some debate. I mean, people had other numbers, higher, lower. That was, kind of a consensus common ground place that people came around to. But that's the type of feedback that I think would be interesting. Changing a 400 to a 500 is not an easy, I mean, these things do take months to get through the process. Folks, the bean counters who keep their eye on the budget and in fairness still want these things to be successful. I mean, the higher that number is, the higher the number going out the door, the higher the bar to clear to show that the model achieves savings. So there's kind of a plus and minus, but you do need people to get in the door. And I think what will be interesting, and if folks have any initial feedback, is where that number is fitting. You know, maybe there's a real need and demand for some diversity here. Shouldn't just be all, you know, large urban hospices. They want some variety in geography, you know, size, you name it. So I think that will be something that they're looking for. And if the industry is saying, look, this number just doesn't work, then they'll have to think about that. Do you think it was too low?
I think it was, but I'm not an expert in that, so
Yeah.
it just seems like it's low.
Yeah. Yeah.
Chris, thanks
I've
so
got
much.
like a soap opera I need to
Oh,
say
good,
it
okay,
too here.
okay. So, you know, about 2 months ago, this group heard from Dr. Bud Hammis, based at Gunderson Lutheran in Wisconsin, who we all know runs an incredibly successful model focused less on the medical side and really more on the planning and the conversation piece. And how do you really engage a person who doesn't want to be a patient, but a person on what their goals, preferences, wishes are when they become seriously ill? And he is way upstream from even the Medicare population, as you know. Can you comment, you know, in terms of all of the different, the ACOs, the bundling, you know, and CMMI, how does advanced care planning play into this? And can you talk a little bit about how we, you know, work with CMMI and with the Hill, you know, based on your experience in the Finance Committee, to think about how to engage consumers more on what they really want when they become really ill?
Yeah, no, it's a good question. I mean, I think that in the Medicare Choices, the concurrent care model, that, you know, the part of what the $400 is going to is that, you know, very upfront, you know, sort of patient-centered, family-centered conversation and care planning process. I think what the point you're trying to make is that may be helpful, and, you know, if the goal is to get people to think about hospice, even when, because as you know, people who are hospice eligible are not necessarily signing up, and they're waiting until they are actively dying to get involved, so there could be some moving of the needle there. But I think what you're talking about is a little more upstream. I mean, to me, that's the type of thing that very well could be happening. I would hope and should be happening, again, with an ACO that is, these people are being attributed based on their use of services from these systems. So these are their patients. And those conversations, while challenging, I think for any ACO that's really looked at evidence and, okay, how are we going to really approach this, I would think would be trying to figure that out. So there's, I guess one argument is if the kind of payment incentive is right and folks, again, have data and maybe some support to figure out how to do this, then maybe it'll happen on its own. I don't know. There may be, I think that, you know, anything around a kind of a federally based campaign on this is probably still premature. I mean, not that it isn't needed, but that politically I think there would still be, at least from the administration, I think some hesitation on that front. That just gets something like a concurrent care where it's really about more choices is one thing I think people would start to maybe feel like getting into things around advanced directives is getting too close to the fire again. So maybe I'm just thinking out loud here. I mean, it may be the work that you and others are doing in the private community to make sure that transfer and, you know, movement of best practices on these things might be the place to go. You know, that being said, I have certainly worked with a number of Republican offices over the years who feel like, you know, advanced care planning, advanced directives is hugely important and very consistent with their philosophy. They just they disappeared pretty quickly once Sarah Palin started tweeting. So maybe they'll be back. I don't know.
So please join me in thanking Chris for a really great presentation and discussion today. And keep your eye on your inbox for the announcement for the next lunch. And thank you very much.
Thanks.